So as I say, I was going to split this into three sections in terms of the first being what's new in the treatment of GIST. The second being why is the mutational profile or the molecular profile of the tumour important? And that sort of factors into the first point in terms of new treatments, because I think with a lot of the new treatments that are being developed currently, we're going to see more personalization of treatment for individual people. And the third, in a way, is a question. Is there a role for artificial intelligence in the early diagnosis and treatment of GIST? So could artificial intelligence be used to diagnose GIST earlier, be able to identify symptoms, and could artificial intelligence guide us in terms of both post-operative treatment, but also treatment for metastatic disease? And I'd say that this is obviously very much in its infancy, but there's a tremendous potential to really sort of revolutionize what we know and how we treat GIST with these 3 points on this slide. So the first is a list, in a way, of the new treatments being developed for GIST. And I'll cover some of the slides, but I won't go into tremendous detail. It's important, as I say, that you ask me questions and we have a discussion rather than me showing you 67 slides of or more. I know. So over the last 5 to 10 years, 2 drugs have been approved. They're not currently reimbursed in the UK, although I hope over the next few months we'll have good news regarding ripretinib. So the first is a drug called avapritinib, and this is a tyrosine kinase inhibitor, which was specifically developed to target a mutation, a GIST mutation, that is resistant to all other drugs that we have. So the PDGFR alpha D842V mutation. And from a phase 1 trial that we did, so a single arm trial of just using that drug, we were able to show that the response rate in patients with tumours with that particular mutation was over 90%. And that led to the FDA approval of that drug for that particular mutational group. In terms of the side effects of that drug, it's in a way quite different to a lot of the other drugs that we use, imatinib, sunitinib, regorafenib, in that it can cause sometimes very subtle neurocognitive side effects. So people have a loss of memory, just feel a little bit hazy. And one of the important things with avapritinib is to identify this early so that we can adjust the dose, adjust the schedule to counteract that particular side effect, because sometimes that can develop and can become very, very serious. In terms of the second drug on this slide, ripretinib, which again is a tyrosine kinase inhibitor, we did a phase 1 trial, again a first-in-human trial of this drug, and it showed very good efficacy in all types of GIST. And this led to 2 randomized trials. So one trial randomizing people with advanced GIST that had already received treatment with imatinib, sunitinib, and regorafenib to either receive ripretinib or placebo. And that trial was conclusively positive in terms of the benefit of ripretinib and led to the approval of that drug. As I mentioned, it's not currently reimbursed in the UK, but NICE is re-reviewing the application over the next few months, and hopefully that drug will be reimbursed in the UK soon. And I think, you know, the work that Just Cancer UK, that everybody has done to try and get that approval is very, very, very important. The second trial was in the second line, so people who'd received imatinib and the GIST had grown were randomized to receive either sunitinib or ripretinib. And for the overall group of people, that trial was negative. But as part of the trial, we collected blood to analyze for ctDNA, so looking for the molecular, the mutations in the blood. And for the cohort of people with ctDNA KIT exon 11 and KIT exon 17 and 18 mutations, the trial was that for that subgroup of people, the ripretinib was very, very effective compared to sunitinib. And that's led to a further trial called the INTRIGUE trial, which has almost completed recruitment, randomizing people with that particular blood profile to receive ripretinib or sunitinib. And it is hoped, in conjunction with other data, that will lead to the approval of ripretinib for that particular mutational subpopulation. So, as I said, the two first points link in quite well together, that I think over the next few years we're going to see a real transition in terms of the way that we use these drugs with an individual person's particular molecular profile. Yes, of course. Yeah, great.
So with the ctDNA, is there any research, or do you see a future where people who are being monitored, like post-imatinib are being monitored, that ctDNA will replace CT scanning?
So that's a fantastic question, and we do have a study looking at ctDNA, looking at ctDNA when people develop growth or develop recurrence on scans. And in an ideal world, I'd hope that we would be able to do that. I think one of the problems that we've identified with the INTRIGUE trial is that the number of GIST patients that we can actually detect ctDNA can be quite low, particularly if somebody is on treatment. So I'd say right now, probably not, but watch this space. And one of the points that we've tried to sort of emphasize, particularly with the INTRIGUE trial, is that we give people a break of a week prior to being screened for the trial, so prior to having the blood test, to see if that will make a difference in terms of being able to detect ctDNA. But when the tumor volume is low, I think in GIST, the chances of us detecting ctDNA is relatively low. So I think the short answer is, in an ideal world, we'd love to be able to do that and to cut down on CT scanning, but I don't think that's ready for for use as routine practice right now. But watch this space.
Thank you.
Nick. Yeah.
So your question just prompted me. Sorry to interrupt. Something I yeah, I know, but this isn't a question. This is something that I've just been waved at by the videographers here. First of all, we are videoing this, and it'll be on the website. So those that want to review what's been seen, you know, what's been said, you can see it on the video. If you don't want to be in the video, I don't know, either you shouldn't be here or you've said you're going to be somewhere, I don't know, whatever there is. Just let us know and we'll try and do that pixelated thing and just say you're SAS or something. But also, if you do want to ask a question, if you could put your hand up, we need to get a microphone to you, because although we might be able to hear the question in the room, we can't hear it on the microphone. So it's not your fault, it's my fault for not saying it. Sorry to interrupt.
No, it's great. And as I say, please do ask questions when they come into your head, because it's good to always ask. And as I keep saying, some of you may have heard this, there's no such thing as a stupid question. There's a stupid answer that I can give, but there's no. So yeah, this is just an outline of the second line trial that, as I mentioned, randomized people to receive sunitinib and or ripretinib with the ctDNA subgroup analysis. And you know, the benefit of ripretinib in this particular molecular subgroup was really quite marked. So for the people with ctDNA detected KIT exon 11 and exon 17 and 18 mutations, the median progression-free survival was over 14 months compared to 1.5 months. So the time for the GIST to grow over 20% was over 14 months. So again, I think this will really change the way that we personalize treatment for individual people in the future. There is a question of how this is going to impact the development of further resistance mutations, and again, it's important that we work with colleagues like Zoe and her team and colleagues all over the world to try and collect more information on how changing that treatment paradigm from imatinib, sunitinib, regorafenib, ripretinib will change if we change, the second line treatment to ripretinib. Nick?
I was just going to say, all of this shows how vitally important it is to get your mutational analysis done as well. So every time, anybody's had a tumour removed, get the mutational analysis done, because it helps direct, and also specialist centres as well.
Totally agree. And in terms of side effects, ripretinib is relatively well tolerated, certainly compared to sunitinib and regorafenib, and the data from the sunitinib versus ripretinib trial confirmed that. Say that the most frequent side effects are usually liver function tests or enzyme tests, abnormalities. Hair loss can be a side effect, unusually with this drug as well. And as I say, this is the current trial allocating people to receive ripretinib or sunitinib based on their ctDNA blood results. So another tyrosine kinase inhibitor being evaluated in the second line is a drug called bezuclastinib. And again, this is a randomized trial, so people who've received treatment with imatinib and the cancer's progressed are allocated to receive either sunitinib, the standard second line treatment, or sunitinib plus bezuclastinib. And I think this trial is going to be really important because it's a combination trial, and whether we can use combination therapies safely with the aim of preventing or delaying the development of further resistance mutations. And this trial has completed recruitment, and we're expecting the results any day now. There's also a trial in the United States which assesses the use of bezuclastinib plus sunitinib in people who've previously received sunitinib to see if it can work in that context. And that's not a randomized trial, but nonetheless will give us really good information about resistance mechanisms. And another promising drug is IDRX42. So this is a drug that is currently being evaluated in a phase 1 trial. Very promising results in terms of both the dose escalation, so phase 1 trial testing different higher doses, and the efficacy results have certainly been very impressive, warranting further evaluation, potentially again in earlier settings, second or even first line. The information so far in terms of the side effects has been promising, but, and it'll be good to open this up for discussion as well, a lot of people experience very severe taste changes with this drug, which can have a real impact on quality of life in terms of wanting to eat and appetite. So it's definitely a very effective drug and will no doubt be evaluated further. So watch this space. Another drug is still got a number as a name, so NB003. Again, we've tested this in a phase 1 trial, and very promising efficacy data. So you can see from these charts that the percentage of people having tumor shrinkage is quite high. So obviously has quite a bit of activity. But I'd say that one of the things with this drug is the side effect of edema. So a lot of people notice fluid retention in the face, around the eyes, and even fluid retention in other parts of the body, which sometimes can be quite disabling. But again, there are ways of managing that with adjusting the dose and schedule, and that's certainly going to be another drug that's going to be evaluated in a randomized trial very soon. And there are a number of other agents and combinations in development, and I'm not going to go into exhaustive detail, but just to mention one, which is a trial that's currently running in the United States of imatinib plus a drug called ziftomenib. And there are a number of laboratory studies which have shown that this combination is really active in GIST, and that combination therapy is actually superior to using just imatinib alone. And this trial is currently recruiting patients. Hopefully we can get this trial to the UK and to Europe soon, but again, a very, very interesting combination worthy of further evaluation. And this is the outline of the current trial, and that's estimated to complete recruitment in 2028. So, in a way, Nick has already highlighted the importance of this, that mutational analysis is really important in terms of guiding treatment, and will become increasingly more important with the introduction of all these new drugs and combination therapies. And this busy slide, in a way, it's almost just to highlight that not all GISTs are the same, and that some mutational types of GIST don't respond to imatinib. And I mentioned the D842V PDGFR alpha mutation. That's a notable example. But of course, there are KIT and PDGFR alpha wild type GISTs as well that we're still really getting to understand the biology of those tumors. And if anything, we should really be offering everybody with these tumors entry into a clinical trial. And again, this just highlights the sort of complexity in a way of just that there are lots of different diseases, different types of mutations. And again, coming back to Nick's point, that it's really important to be treated at a specialist centre, that people are familiar with these different types of GIST and know what is the best standard treatment for your individual type of tumour. And there's a sort of context here, even in terms of the use of imatinib, the combined analysis of the EORTC and the North American trial of 2 different doses of imatinib, 400 and 800 milligrams, showed that in KIT exon 9 mutations, that 800 milligram is more effective in terms of the tumor shrinkage, but also in terms of the length of time it takes for the tumor to grow. On a positive note, I think IDRX is a drug. IDRX42 is a drug that we're very interested in terms of treating tumors that have the exon 9 mutations. So again, watch this space. And this is just an example of how important mutational analysis is. So this is a gentleman initially referred to us back in August 2016. The tumor had a D842V PDGFR exon 18 mutation. The tumor had unfortunately progressed on sunitinib and regorafenib. We just opened the phase 1 trial of avapritinib at that time, And essentially, the tumour just melted away, and the residual tumour and metastasis, Turk Strauss, one of our surgeons, resected that, and we carried on with avapritinib at the dose of 100 milligram every 3 days since June of last year. But this gentleman is doing really, really well, continues on treatment almost 10 years after entering the phase 1 trial. So again, highlights the importance of mutational analysis, but also trying to use trials as part of treatment to, in a way, be strategic and use the trial when it's available so that people have more options. And this just shows you that the size of the tumour when first referred to us. So absolutely massive tumour with an omental metastasis, over 40 centimetres. And this is the pre-surgery CT scan showing how much the tumour had shrunk. And we've got a more up-to-date scan, but essentially it just shows the same thing, which is a really, really good response. And as I say, there's a lot that we need to try and understand in terms of KIT and PDGFR alpha wild-type GIST. That's almost a lecture in itself in terms of the heterogeneity of these tumours. And of course, there is the GIST Pause Clinic in Cambridge that we're a part of. But again, clinical trials are really, really important in terms of offering people the most up-to-date and most suitable treatments. Good. So the last part you'll be pleased to hear. Oh, there's a question. Fantastic. I was getting tired of my own voice. But
yeah, I've just got a question about clinical trials from the patient's point of view. If you've been on a clinical trial, are you able to participate in another one in the future, or is it like you only get one go?
The answer to that is yes. In general, there are certain caveats depending on the eligibility, but I'd say in the vast majority of cases you should be able to go on to a clinical trial in the future. For some of the early stage early treatment setting trials, so if a trial is in the second line setting and you've had 4 or 5 lines of treatment, then by definition, unfortunately, you can't go into that trial. But as a general rule, entry into clinical trials shouldn't exclude you from entering a further clinical trial.
Just one other question. If the order in which you take the drug seems to be quite fixed at the moment. So, I've been told, for example, that so I'm obviously on a clinical trial at the moment. When that doesn't work, then it would be you go on to sunitinib. But sunitinib wouldn't work or it's already been shown not to necessarily work for the mutation that. So, like you were saying, will there be scope for clinicians to choose the order in which drugs are given, rather than it has to be this order before you're allowed a certain drug?
Yeah, again, I think that's a fantastic question. So, in an ideal world, I think it would be good for the clinician to be able to, weigh up different treatment options with the individual person. In the UK, the reimbursement system can be relatively rigid, but I'd say that that the scene is changing, and depending on the clinical trials that we have available, I think there is scope for being creative in terms of how we use different drugs. I think in countries like Germany and the United States, it's a little bit easier for clinicians to use their knowledge in terms of the biology of the disease to guide treatment, whereas in the UK things are a little bit rigid, but I think there's definitely scope for being able to try and select the best treatment for an individual person, particularly within the context of a clinical trial, which ties in with your earlier question about does a clinical trial exclude somebody from a further clinical trial? Yeah. So, but that's a really, really important question. And I think one of the things is that we really need to be able to, collect blood specimens and tumour specimens from patients so that we understand more what happens now that we are changing the order of the drugs in terms of the mutational profile and the resistance that develops.
Thank you.
No, thank you for asking the question.
It might be beneficial if you could say a little bit about the process by which people get on clinical trials if they're interested. I think it might be relevant to them.
Yeah, so it depends on the type of clinical trials. So I'd say that for GIST, the main ones are either phase 1, which are to find the right dose, to find the side effect profile of the drug, to find the way that the body metabolizes the drug, and in terms of entry criteria, they tend to be more open than a randomized phase 3 trial, which is basically designed to show that a new treatment or a new combination is better than the standard treatment. So that comes back to the earlier question regarding eligibility to clinical trial. If a phase 3 trial, randomized trial, is looking at what is the best second line treatment and you've had 3 lines of treatment, then it's not going to be possible to get onto that trial. Whereas with a phase 1 trial, because it's in an earlier stage of development, maybe open to more flexibility in terms of lines of treatment. In terms of the general entry criteria, there are requirements in terms of kidney, liver, bone marrow function, concurrent medical conditions. They are generally relatively similar, but can vary slightly between different trials. But again, that's an individual discussion with your oncologist about the eligibility and what's the best option for you. But in principle, for GIST, I think basically falls into almost 2 camps in terms of the trials that are available. It's either a randomized trial or a phase 1 trial, which is either finding the right dose or is expanding the best dose with participation of more people, if that makes sense.
So how long should you have to wait till you get to know what your mutation is, and after you've had your sample taken, and why don't they just put you on imatinib straight away to try and shrink it while you're waiting? Yeah,
so that's a good question. I suppose it varies with different labs. Sometimes it can take a few weeks for the mutational profile to come back, simply because a lot of samples are done at the same time, so they almost batch them in a way. I'd say in terms of starting imatinib empirically without the mutational profile to try and shrink a tumour, that is something that we do relatively often while we wait for the mutational profile to come back, because the vast majority of people will have tumours that will respond to imatinib, and the side effect profile is pretty good. And then depending on the mutational profile, we can change treatment as required. I've mentioned in particular the D842V mutation, which doesn't tend to respond that well to imatinib, but I've seen people with tumours with that mutation that have had really good responses to. So that there can be a little bit of variability there. And starting imatinib empirically sometimes is a good thing to do, while you're waiting for the mutational profile to come back, particularly if somebody is unwell. It's really important to try and get somebody on treatment, because there's a high chance of success with imatinib.
And this may be a weird question, but
I'll give you a weird answer.
Is it kind of true that generally they're slow growing, or is that a bit of a fob off?
I suppose, the trouble with medicine, you can never be absolutely black and white about things, and there are people in clinic that have high-risk tumours, tumours that were fast-growing, but haven't developed recurrent disease, whereas there are other people with slow-growing tumours in a way, but unfortunately have developed recurrent disease. So I don't think it's an absolute in terms of that risk. And one of the things about artificial intelligence is almost, will we be able to use that to sort of better predict not only the risk of recurrence, but also the response to drugs like imatinib? Because in a way, the tools that we have right now, tumor size, position, mutational status, mitotic count, or how fast the tumor's dividing, they're good, but there's probably more to it than that. And there's a definite need for refinement.
Can I just ask, does the mutation actually change ever, and how often should you have a new DNA profile of it? Yeah, so
again, there's a lot of variability. I think, unfortunately, for instance, if somebody's on imatinib and the cancer, the GIST gets worse, it grows and spreads elsewhere, then there's been a definite change within the tumour, and resistance mutations have developed. I suppose compared to other cancers, the interesting thing about GIST is that the mutation, that resistance develops within the same lineage, so within KIT or PDGFR alpha. So the resistance mutations, unfortunately, do develop for a lot of people, but on the other hand, there are people that have been on imatinib for years and years and years, and with no sign of cancer progression, and clearly no resistance mutations have developed in that setting. Mm-hmm.
And should you have it checked?
I think so. That's the really interesting thing about the INTRIGUE trial, in terms of using the that sort of resistance mutational profile to try and guide treatments. So I think if everything is going well on imatinib, then clearly there's no need to recheck. But if there's progression of the GIST, then it would be a good idea to check. I think that the overwhelming feeling is that the INTRIGUE trial is going to be positive, just because of the subgroup analysis of the previous trial. And if the INTRIGUE trial is positive, then that's clearly going to change the way we approach the second-line treatment, where ripretinib has such a benefit for patients with KIT exon 11 and KIT exon 17 and 18 mutations. So as I say, watch this space, because I think things will definitely change. Thank you.
Hi, just changing slightly the subject. Leslie here is an excellent cook, and I love my food, but I can't taste it. And I'm on sunitinib 25, and my taste is totally gone, and it's giving me misery. I'm sure there are far worse side effects in life. I have had them. In fact, Dr. Justin Waters has contacted you about me. I'd like to have a little word afterwards. but meanwhile, food. loss of taste. Is there anything you can suggest, recommend?
Again, that's a fantastic question, and I wouldn't underplay the impact that something like that can have. I was chatting with somebody earlier on, and even though we may, classify that as quote unquote low grade in terms of side effects, it can have a profound impact on how somebody enjoys their life and their quality of life. I'd say that there isn't an easy answer in terms of one sort of magic wand solution. Sometimes with sunitinib, and I'm happy to have a chat with Dr. Waters about this, I sort of varied the dose even lower than 25 milligram, and there are other subtle things. Maybe we can chat after this session, and there are things that we can potentially do in terms of the time that you take the drug, adjusting the dose and the schedule a little bit. And I'd be happy to chat to Dr. Waters about that.
But if we could have a little chat after, I'd be very grateful.
Yeah, no.
But sweet things, ironically, you can
it's
taste
interesting.
more
It's
or less
interesting.
as normal.
Yeah.
But I've never been a dessert man, ever. It doesn't help. But
No,
anyway,
Dr. Waters is fantastic, and I'd be really, really happy to chat to him. As I say, there's no sort of magic wand solution, but it's trying to sort of just adjust things a little bit. And other people have noticed that different types of food agree with them more. And I fully take your point regarding. I'm the same. I'm not a dessert man, so that's, yeah. But it'll be good, and as I say, really happy to chat to Dr. Waters as well.
Hello, I have a question about more like holistic approach, because I'm on exon 11 and on imatinib for like 3 months now. I had surgery before, so currently I'm not. But I have recently developed like a kidney problems, and I just want to basically ask where I can get help with basically protecting, finding a ways to protect my kidneys and liver while on imatinib, because when I go to my appointments with oncologist, I only talk about imatinib and kind of side effects that I can manage more easily, but those in the long term I would like to find out what can I do on a daily basis to basically give me better chance to have stronger kidneys and stronger liver, to be able to be on a treatment for longer.
Yeah,
term.
again, that's a really, really good question, and I fully take your point. Sometimes, as oncologists, we're really sort of focused on the imatinib's working, boom, boom, boom. I think one of the things is how severe is the kidney side effect, in terms of the kidney function, and whether then there's a need to take a break from imatinib just to let the body recover. I'd say with side effects like that, if it is due to the drug, it's very difficult to do other adjustments to counteract the impact of the drug on that particular organ. It's quite rare with imatinib to have really bad side effects like poor kidney function or impact on liver function. But one of the things that we do is to just give a break from the treatment. In terms of holistic care, I think you're absolutely right. I think that's important in terms of just general treatment anyway, and important in terms of exercise, healthy diet, moderation in terms of what you eat, taking on board the point regarding sweet foods and everything. I think that that's really, really important, and there are people that we work with who, you know, advise on just that sort of holistic lifestyle approach to things. But I would emphasize if imatinib or any other of these drugs is causing a problem with a specific organ, if it is due to the drug, it's very difficult to make other adjustments to counteract that. But I do think that a holistic approach is really important in terms of somebody's general well-being and you know, quality of life, even though it may not rectify a side effect like that. So I think that really needs to be taken seriously and investigated further.
Thank you. And I also have one more question, and probably it's a very grim question, but I usually get more information from like Facebook forums for these patients than from actually the doctors, because yeah.
I was going to tease you, but that's why I like you asking me questions.
But actually, the question that I have is, if I get recurrence, what is the prognosis in terms of, you know, how long I might be able to live after the recurrence? Because at the moment I just don't know, and I would like to have at least a bit of a plan, you know, in terms of my family and future.
Again, maybe I can have a chat with you after the session so that we can discuss that. But as a general sort of principle, even if there is, you know, even if the cancer does come back after post-operative imatinib, there is still a high chance of imatinib working, and there are lots of other drugs in development. But the sort of specifics, you know, it's very individualized in terms of the type of tumor, et cetera, and maybe again and I'd be happy to talk to your oncologist as well about that.
Thank you. I only know that when I went to my first appointment, when I was told that this was GIST, when I asked how bad it was, the oncologist told me, if you have to have a cancer, this one is quite good to have. So this gave me a little bit of
that's what I mean. Even if the
hope.
cancer does come back, then, you know, there's still a lot of good things that can be done. So I wouldn't view it entirely as a sort of grim situation. And, you know, conversely, you know, it may never come back. So, you know, I'd be very glass is half full. But again, in terms of specifics, it may be better that I, you know, speak with you or speak with the treating oncologist. And really, really happy to. Oh, pleasure. Yeah.
Is it normal for everybody post-operation to go on some kind of drug treatment in it to be able? Is that common that you can expect that to happen once you've had your surgery, or does it just depend on the mutation and where it is?
It depends on the risk status of the tumour. So if the tumour is a high-risk tumour in terms of the size, the mitotic count, so that how quickly the cells are dividing, the position, and in a way the mutation status, then that's you know, that will guide. So not everybody will receive post-operative treatment.
Yeah, no, so I was actually in that situation you were talking about where I was put on imatinib while waiting on the mutational testing, but then I have this PDGRA
DH4TB. Yeah.
So it was kind of a wasted effort in a sense, and actually there was a bit of a confusion. I thought I'd had the mutational test, and I presumed that I was being put on it because I had one of the mutations that responded to it, but in the end I didn't. And actually, if I'd known that, I would have held off, because it's quite a bit of, for me anyway, personally, it was quite an effort to start the drug, because it's preventative, but with my particular kind of risk profile, it was kind of a balance of whether I should even start it or not. It was kind of a marginal benefit. So I think for me personally, if your oncologist thinks that you've got a bit of time to wait, I'd wait, because actually I've got myself in the situation of I worked myself up into taking it. I'm taking it because I think I need it, and then I'm being told there's kind of nothing to take. You know?
Yeah, your point's really, really well taken. I think in the post-operative setting that definitely applies. When somebody, unfortunately, sometimes people have disease that's spread elsewhere, and if they're feeling unwell, then that's a really good rationale very often to empirically start imatinib just because somebody may not be feeling so good, and then to adjust the treatment as required. So your point's really, really well taken, that the treatment setting is obviously important in terms of that decision for starting a tyrosine kinase inhibitor. So really, really good point. Really, really good point.
Similar type of area, really. Yeah, is there a way of, I guess the question is there a way of doing the mutation analysis after one has started on imatinib? Because that's kind of what happened to me. They did the biopsies and what have you, went away for tests, started on imatinib, and then got no kind of clear answer from the mutation analysis in the tests. So you're left with okay, we just don't know, but 6 months later does seem to be shrinking. So
if the tumour is shrinking, then the answer's there. So I'd hold fire before doing a repeat biopsy, or using ctDNA, depending on what happens with with these ongoing trials. Yeah.
But that is the way that you get an answer later on once you're actually into a drug treatment, the ctDNA type of analysis.
And I suppose if imatinib is working on, the scan shows that imatinib's working, as previous question in terms of what happens, well, resistance does develop, and it may be better to get a more up-to-date impression or analysis of the tumour at that time. Again, a lot of this is not. I suppose that's the challenge with medicine. It's all very sort of black, grey rather than black and white. Yeah.
I want to try and move us on to the AI bit as soon as we can. But
sorry,
question
that's my fault. I'd say.
Hi there. You were talking about ripretinib being a second-line drug. If it ever comes to be approved, will it also be available as a third or fourth line drug?
Yeah, so very good question. So the current NICE review is for fourth line. Based on the that randomized trial that I mentioned to you that allocated people to either receive ripretinib or placebo with crossover to ripretinib. So based on that, we're hoping that it will be reimbursed there. But the ctDNA trial for patients with blood tests that show ctDNA positive for KIT exon 11 and KIT exon 17 and 18, if that trial is positive, we're hoping that ripretinib will be available for that cohort of people in the second line. So really, really good question.
And on trials, do you need your line drug to actually fail before you are on being accepted?
It depends on the particular trial, but in general, the trials will, as a prerequisite, require that the cancer's grown on previous treatment. So if a treatment is working for you, we generally wouldn't recommend changing treatment. So that's usually a prerequisite. And apologies, I didn't mention that earlier on, but yeah, thank you.
Hi, Prof. Jones. Thank you for your fantastic overview of the sort of clinical trials field at the moment and what's coming through. And you have a really great bird's eye view of what medicines are arriving on the market, but what would be your 3 basic science research priorities that you would like to see to drive the field towards cure?
So that's a fantastic question. The first question that I'd like to answer is why do some people have tumours that never develop resistance to imatinib, never develop disease progression, and others do develop resistance mechanisms? What is the difference between those two cohorts? What is the difference in terms of the biology of those two tumours, in terms of essentially being the same type of tumour, so a GIST with the same mutational profile, but there must be something different in the biology that drives some of these tumours to develop into worse tumours with worse biology. The second sort of fundamental question would be, from autopsy series, it's clear that up to 30-40% of the population have microgysts that are completely asymptomatic and are just discovered coincidentally. So they're really common, but full-blown GISTs are relatively rare, despite being the most common subtype of sarcomas Nick mentioned. So one of the things that I'd really like to look at is what's so different about the sort of, the surrounding immune environment, the physiology of that individual person that stops that microgist from developing into a full-blown gist. And maybe Zoe and the team, we can do something to look at that, because I think that's almost a really sort of fundamental question in terms of why some of these tumours obviously progress. And the third question is, again, it comes down to the to the management of metastatic disease and the biology of metastatic disease. In some patients, we can eradicate the disease with surgery. And I go again, what is the reason for that? Why? Because if it's a systemic disease, why, in conjunction with a tyrosine kinase inhibitor and surgery, or even a local therapy like ablation, why can we, in a way, cure that disease? What is the reason for that? What is the sort of underlying biology there? Because again, maybe the same type of GIST in terms of, well, same mutational profile originally, but what happens, and why is that the case? So those would be my three questions, but really open to other people's suggestions. The question regarding microgist, it really is something that we should look at. And I was chatting with, I mentioned to Zoe, with M&A, one of my colleagues earlier on, about just looking at the surrounding immune profile of microgist specimens, not just looking at the microgysts themselves, but is there a difference there in terms of what happens and what subsequently happens? So maybe, Zoe, that's something that we could... You should never ask me this. I get really philosophical when somebody asks me a question like this. Yeah. But that's a really good question. And
he's good, isn't he? It's good that we've got this expertise, isn't it? It's brilliant.
But number two is probably my preference, because number two would mean that we would be able to really get to the nuts and bolts at the start of the disease, rather than trying to treat metastatic disease, if that makes sense. Yep. Yeah.
So, with a view to moving on, I just wanted the comment that you made earlier about prognosis for the future and everything. So, my GIST was 8 centimetres in my stomach, removed, all margins clear. Good news, good news, good news. My totic count, 68. It's one of the highest I've ever seen. Probably you've seen as well. So Ian Judson, Professor Ian Judson, who's another expert within GIST, said to me, it's not if your tumour will come back, it's when. I'm now 15 and a half years down the road, it's not come back. And I don't mind saying that, because I've said it a lot and it's still not come back. So you know, but bear in mind everybody seems to be different, and you know there's no general trend. So the other thing I was saying, those that know me will hear me say this all the time: positive mental attitude has a big positive effect on it. I'm going to take one more question just here, and then we're going to move on to AI, because we've got like 10 minutes left, if that's okay with you.
Yeah, of course.
Sorry, just quickly. We've just started on this journey. My husband was diagnosed 8 weeks ago with a malignant cyst. It's 12/10 in his stomach. We live in North Devon. People keep going on about you should be seen by a specialist hospital. That's key to the treatment, as well as positive attitude, which is what we've got. How do we get referred to a specialist hospital? I believe our nearest one is Bristol. I did phone them, but they basically said we would only go there for the operation. At the moment, an operation's not even on the cards for my husband because it's already hemorrhaged and the size that it is. So, but you've had one removed, and so I don't know how we get. Being new to the journey, how do you actually get to a specialist hospital?
So I'd actually just ask your team to refer and to ask for, even if it's a sort of a verification or a rubber stamp of the management plan from a specialist centre. That would be the way that I would approach it. And usually, the treating oncologists are very sort of open to that. So I would do it that way. What I can do is maybe again, just in terms of an individual scenario, it may be good if I catch it. Yeah, that may be. The surgeons won't be happy.
I reckon you'll be here for lunch, I reckon. Right.
Again, it's a big trouble. No. Oh, this has been recorded. Yeah. So this is just a really brief highlight, in a way, of some of the work that's been done already in terms of artificial intelligence. And just, I'd say that as this is still in its infancy, and a lot of these studies are really small and are retrospective, single center, but I think we really need to, move forward in terms of trying to look at this and, trying to sort of treat and to intervene at an earlier stage, coming back to the question regarding the 3 biological questions on GIST. If we can intervene before a GIST actually becomes a full-blown problematic tumour, that would be fantastic. And again, in the interest of time, I won't go into too much detail, but just highlight that there have been studies looking at using artificial intelligence to try and identify the type of GIST in terms of molecular profile. And, this is, in a way, really almost quite scary in terms of the way that artificial intelligence can do this. And we don't really understand how the process is relatively opaque. And I probably shouldn't get into philosophical dialogue now. We maybe can leave that till later. But there's obviously a huge potential here in terms of making the diagnostic process easier and better. And also in terms of endoscopic ultrasound, so an endoscope with an ultrasound at the end that AI can identify a GIST from other from other mesenchymal benign tumours. So again, the potential is just tremendous. But I think the thing that really sort of scares me is we don't understand how artificial intelligence actually does that. And also the use of radiomics in GIST and in other sarcomas is absolutely fascinating. And radiomics being a technique to extract a huge amount of information, a huge amount of data from radiological images to try and predict characteristics of the tumour. The Memorial team with Sam Singer have published a number of series recently regarding the use of AI to both predict recurrence, so that comes back to some of the earlier questions that we had, to use better methods than just using tumour size, mitotic count, anatomic position, mutational status. And again, these studies are, they're early. There's clearly a lot more work to do, but it just shows you the direction of travel. And Dr. Singer's team have also used AI models to guide treatment optimization, which again was one of the questions that somebody in the audience asked earlier on. So there are ways that we can clearly improve treatment using AI, but the thing that in a way scares me is that we don't really understand how they work. And again, a small study showing that AI can guide the prediction of the developing metastatic disease. As Nick mentioned, right now, it's very sort of hit and miss really in terms of that prediction. And we've got an AI component in one of our sarcoma grants, and one of our PhD students published this in Lancet Oncology last year, or the year before, looking at the use of radiomics to actually better classify tumours rather than just using a preoperative biopsy, and therefore being able to better guide preoperative treatment, because when a tumour is huge, if it's 30, 40 centimetres, then a small biopsy may not be representative of the entire tumour. So I put will likely revolutionise. I mean, it will revolutionise diagnosis and treatment in GIST. But a lot of the current studies are limited because they're retrospective, small single institution cohorts. And how do we actually explain how AI actually comes to these conclusions is something that I'd really like to better understand. And of course, reproducibility, so that these techniques can be used in the general clinic setting. So in terms of a conclusion for these 3 points, there are clearly a number of really promising drugs in development for GIST, and a number have already been approved. This has big implications in terms of further treatment, both in terms of the use of ctDNA, the use of combination therapies, and one of the big questions is the sort of what is the benchmark in terms of second-line treatment, third-line treatment with sunitinib and regorafenib. I mentioned the ripretinib versus sunitinib trial earlier on, and it's clear that the sunitinib population in that trial did much better than the placebo-controlled trial that led to the approval of sunitinib. So, the oncologists have become better at using the drug, at adjusting the dose, managing the side effects, so that these benchmarks may no longer be as applicable. And the second point, as Nick mentioned, I mean, mutational analysis is clearly important and will become even more so with the results of ongoing trials. And again, AI will clearly change diagnosis and treatment. So thank you so much. Thank you for all the great questions as well.
Thank you. I've got something to add to the AI. So I was in a meeting yesterday with Cancer 52, the other charity that I'm involved with. I don't know whether you know about this, the pinpoint test. Does that mean anything to you? No, it's new, really new. So this is hot off the press. So this is a blood test. I'll just read what it says. So Professor Sean Duffy, I don't know if anybody recognises that name. He was the previous clinical director for NHS England, so quite a senior man. It's a new test. It's a proprietary machine learning algorithm. Machine learning unlocks the ability to do what no doctor can, analyse patterns and linkages within the data to derive an aggregate risk of cancer, basically it's a blood test that can give you a guide on whether or not you are likely or not to get cancer. Really, really early stages of it, but you know, I asked him, at the moment they're doing trials and tests with people that already have cancer in order to find out whether or not this is working to say yes, because clearly if that test for somebody that has cancer says no, they're unlikely to get cancer, well then there's something wrong with the test. They've had all positive results so far. So my question to him was, is this going to end up, and is the goal to end up for it to be a proactive test, one that everybody, if they want to, can have, if they want to, and that's a big if as well, because a lot of people don't, for some reason, don't want to know. But we all know early diagnosis is the best way to get treatment and cure for cancer. So therefore, if there's a test that, I'll put this down, if there's a test that can tell you whether you might get it, and furthermore using AI which one you might get, then there are more chances of you being getting the diagnostic tests in place in order to keep a check on you to see whether you get it. And my second question was, if that's the case, how far are you bringing the NHS and the government along with you in order to pay for this to happen? His answer to that was, they are coming along with him, but they're having problems with the central part of government really getting on board on it. And this is where this networking, it says it on here, comes into what we do as well. Because Cancer 52, like I said to you, is a organisation that represents us at governmental level. So we had a board meeting the next day where we discussed this test and the difficulties he's having getting government involved. We've now got a meeting with the Secretary of State and Health within 2 days, so that, and I'm going to that meeting to get him at the table with government again in order to try and move this forward, because I think this could be revolutionary.
Yeah, I
AI.
agree. So early intervention is so much better on so many different levels, and I think it's so much easier to treat early rather than to treat metastatic disease. So it's trying to sort of get that message across, I think, is the really hard thing.
Because at the moment it's symptoms that lead people to go to see their doctor. But if you can have a regular blood test at regular intervals during your life and preempt that you might get it, it's great. And bear in mind, he was talking to an audience of rare and less common cancer charities. So, you know, although this is a predictor for the 4 main ones as well, the emphasis on this was rare and less common cancers. Right, we are past 1:45. I know there are more questions for you, Robin. So what we'll do, if you don't mind, is we'll now move on to the next agenda item. And first of all, thank you so much.
Pleasure, as always.